Hi friends, in this video we are discussing about the drugs and management of uncomplicated or complicated urinary tract infection in pregnancy, which is non-pyelonephritis in origin. This video is completely based on an evidence-based approach discussion. As we know, UTI or urinary tract infections are common during pregnancy because of the physiological and hormonal changes of the pregnant women. If it's left untreated, they can lead to complications like pyelonephritis, preterm labor, or low birth weight. Thus, accurate diagnosis and evidence based management are crucial for the health of both mother and fetus. This presentation or this video outlines the recommended treatment options for managing uncomplicated and complicated UTI in pregnancy, excluding cases of pyelonephritis. It means we are discussing about asymptomatic bacteriuria, urethritis, or cystitis. So, this focus will be on safe and effective antibiotic choices, guidelines of therapy, and important precautions need to take care during pregnancy treatment. So first we can move to the first line of antibiotics. We have mainly two choices of first line. One is fosfomycin and the second option is nitrofurantoin. If it's fosfomycin, it's administered as a single dose oral sachet of 3 grams and it's particularly useful for uncomplicated UTI and it is safe for use in pregnancy. So importantly, fosfomycin, as it will not achieve therapeutic sufficient concentration therapeutic level in kidney, it should not be used in case of pyelonephritis is suspected. And next option is nitrofurantoin. There are two types of nitrofurantoin dosage forms available, which is extended release form and immediate release form. If it's extended release form, we need to use 100 milligram twice daily for a period of 3 to 5 days. Where if it's immediate release form, we need to use 50 to 100 milligram 4 times daily for 3 to 5 days because of its short half-life. So the nitrofurantoin is effective for lower urinary tract infection, but it have its own some limitations. As like fosfomycin, it will not reach therapeutic levels in the kidney, so it should be avoided in pyelonephritis. Additionally, the issue with nitrofurantoin is nitrofurantoin should be avoided near the end of pregnancy or at the term because it will cause a risk of hemolytic anemia in the newborn. So these options are generally well tolerated and effective for uncomplicated cases. Next, we can move to the second line antibiotics. If the first line therapies are unsuitable or ineffective, the second line antibiotics can be considered. The first option is cephalexin, which is prescribed at 500 milligram orally twice daily for a period of 7 days. It's a safe and effective choice which is widely used in pregnancy. Next option is amoxicillin. The dose is 500 milligram orally 3 times a day for a period of 7 days. However, its effectiveness may be limited against gram-negative pathogens as resistance is very common. The third option is amoxicillin clavulanate, which is prescribed as 875 milligram orally twice daily for a period of 5 to 7 days. This combination of amoxicillin clavulanate or augmentin is effective for a broader spectrum of bacteria. Next option is cefpodoxim, which is given at a dose of 100 milligram orally every 12 hourly for a period of 5 to 7 days. And it's another cephalosporin option that is considered to be safe in pregnancy. The next class is pumeselinum. This is commonly used and approved in some specific regions. In the United States, it was approved recently in April 2024, and its typical dosage range is 185 milligram pumeselinum base, which is equivalent to 200 milligram of pumeselinum hydrochloride, 3 times daily for a period of 3 to 5 days, or as per European guidelines is 400 milligram 4 times daily for a period of 3 to 5 days. So it is important to note that pumeselinum should not be used in case of pyelonephritis as we discussed for the first line agents because it will not achieve therapeutic concentration in the kidney. So each of these antibiotics can be used depending upon the local resistance patterns, patient allergies and culture sensitivity reports. Next, we can go to or move to the topic of antibiotic, which is not recommended in pregnancy. Certain antibiotic classes, which are contraindicated, are not recommended during pregnancy due to its potential harm to the fetus or ineffective outcomes. The first class is fluoroquinolones, which is associated with the fetal cartilage damage. So it's mostly avoided in case of pregnancy. Next class is tetracyclines, which can lead to permanent discoloration of the teeth of fetus, so it's avoided in pregnancy. Next is Bactrim or trimethoprim sulfomethoxazole combination or cotrimoxazole combination. It should be avoided because of the risk of neural tube defects in pregnancy, especially in the first trimester. So it's avoided in such cases. Next, we can move to the topic of guidelines, recommendations for this treatment. So first, we can discuss regarding the pregnancy specific considerations. During pregnancy, all forms of UTI, including asymptomatic bacteriuria, cystitis, urethritis, should be treated as they increase the risk of adverse outcomes like preterm birth and pregnancy loss. So it should be addressed and it should be treated accurately. The next topic is culture and sensitivity testing. Culture and sensitivity testing is most important, and these tests are essential to identify the causative organism and to guide the antibiotic selection, as the empiric therapy should always be adjusted based on the culture results. So the third topic is safe antibiotic options. As we discussed, the first line option like nitrofurantoin and fosfomycin are preferred, but with limitations such as avoiding nitrofurantoin near term. We should consider those things. So next is penicillins and cephalosporin, which are considered as a safe alternatives depending upon the bacterial susceptibility. And the fourth topic is the special notable amoxicillin. Amoxicillin, this drug should only be used when the infection causing bacteria confirmed to be susceptible to it, because the resistance to amoxicillin is very common as it's a very commonly used antibiotic. Next topic is GBS or Group B streptococcus treatment in pregnancy. The pregnant woman with either symptomatic or asymptomatic GBS bacteriuria should receive treatment to prevent neonatal GBS infection. So as per the CDC guidelines, recommend treating at any detectable level of GBS of bacteriuria. The preferred antibiotic for GBS is penicillin, which is safe and effective. Additionally, intrapartum prophylaxis is required for cases to prevent early onset of neonatal GBS disease. So next we can move to the summary of guidelines, the major guidelines. The Infectious Disease Society of America or IDSA and the European Association of Urology EAU provide specific recommendation. As per IDSA, the treatment of asymptomatic bacteriuria should be done with a duration of 4 to 7 days, which is the course of antimicrobials, and we should select the shorter effective duration, which should be preferred when supported with the evidence. As per European Association EAU guideline recommendation, it's also telling about the short course treatment, like the short course treatment of 2 to 7 days, or the single dose therapy like fosfomycin are effective for the treatment of cystitis. So in conclusion, the management of UTI during pregnancy require careful balance between efficacy and safety. Adhering to evidence-based guidelines ensure optimal outcomes for both the mother and the fetus while minimizing the risk of resistance and adverse drug effects. Always prioritize culture and sensitivity testing to guide the therapy. Thank you.